Hi, I'm Dr. Joanne Manson, Professor of Medicine at Harvard Medical School and Brigham and Women's Hospital. I'm an endocrinologist, and we've recently published an update to the Women's Health Initiative findings in JAMA. The Women's Health Initiative is the largest randomized clinical trial of hormone therapy that was sponsored by the National Institutes of Health. It was designed to test the balance of benefits and risks of the two most common formulations of hormone therapy, conjugated estrogen alone or combined with MPA, in women aged 50 to 79, a broad range of postmenopausal age groups, in order to evaluate the role of hormone therapy in the prevention of chronic disease. The WHI was not designed to evaluate efficacy for treating hot flashes or the balance of benefits and risks for the purpose of treating hot flashes in early menopause. So it's a really important distinction. The two trials were stopped early. The estrogen plus progesterone trial was stopped after a mean of 5.6 years in 2002 because of an adverse balance of benefits and risks and an increased risk of breast cancer. And the estrogen alone trial went longer for a total of 7.2 years, but was also stopped early, 1 year early, due to an increased risk of stroke. Well, there are several known and well-established benefits of hormone therapy. It's the most effective treatment for hot flashes, night sweats, and it reduces the sleep disruptions that are related to these symptoms. It also is helpful for bone health and is linked to a lower risk of hip fracture and total fractures, about a 30 to 35% reduction in osteoporotic fractures. And it also is helpful for genitourinary syndrome of menopause related symptoms and for dyspareunia and discomfort with sexual activity. So it has a number of benefits. Well, it's very important to look at all-cause mortality because it's a vitally important summary measure of the net effect of a medication or an intervention on serious and life-threatening health conditions. And especially when you're talking about a medication as complex as hormone therapy, which has such a complex matrix of benefits and risks, looking at all-cause mortality it's really the ultimate bottom line in terms of understanding its net effect. And so we were really interested once we had long-term follow-up in looking at total mortality as well as cause-specific mortality, deaths from cardiovascular disease, cancer, other major illnesses during the treatment phase as well as over the cumulative 18 years of follow-up. So in the overall cohort, there was no signal for increased risk of premature death or either increased or decreased mortality in the mean age of 63 in the cohort. When we looked at the results stratified by age group, there was a signal toward lower risk of mortality in the younger women. The women who were age 50 to 59 when they enrolled actually had a reduced risk of all-cause mortality, and there was a significant trend by age such that their results were more favorable than the results for the older women. But even for the older women, there wasn't clear evidence of increased all-cause mortality. Well, these findings that there was a neutral overall effect on all-cause mortality and even a trend toward favorable results in the younger women provide support for the recommendations of professional societies endorsing the use of hormone therapy for management, treatment of vasomotor symptoms, other menopausal symptoms, especially in early menopause. There would be no reason to withhold hormone therapy from women who are having bothersome menopausal symptoms and would have quality of life benefits from treatment. However, the findings do not provide support for the initiation of hormone therapy for the express purpose of trying to prevent cardiovascular disease or other chronic diseases of aging, especially in older women, because overall we did not see a benefit for mortality in the older age groups, and there were greater absolute risks identified in older than in younger women. Although the WHI tested the most common formulations of hormone therapy at the time the trial started, which was in the early to mid 1990s, and that was the conjugated estrogen alone or with MPA, currently it's much more common to use estradiol and transdermal routes of delivery as well as micronized progesterone. So we need additional research on the balance of benefits and risks of these newer formulations that are in more common practice today. And there is some reason to believe that the transdermal route of delivery would be safer, especially in terms of thrombotic, venous thromboembolism, and thromboembolic outcomes.